Yes. And now we go back to this, and we go to this. And I share. And where are we sharing? Wait a minute here. Why am I? Hold on. Now, see, I was so excited because I thought I figured this out. Okay, just a minute. Oh, this is what I want. Okay. Are we good? Are we recording? Are we hearing me? Are we seeing me?
Yes.
Okay, perfect. All right. This is we're going to talk specifically right now about hip replacement surgeries here. And again, this is often a result of osteoarthritis. They don't do this for rheumatoid arthritis. Because it doesn't matter, because rheumatoid arthritis is going to be a synovial membrane problem. So fixing the hardware of the joint itself is not the issue. So they do this for osteoarthritis, and this is wear and tear. And when you get bone on bone, when you have lost that cushion between the bones, and now we are grinding. You can feel the grinding, you can hear the grinding, and it is so painful. So when it gets to a point that it is affecting the quality of the life of the patient's life, where they can't even walk anymore without being in excruciating pain, despite being on analgesics, then the resort is going to be joint replacement surgery. Now, the thing about it is they don't like to do joint replacement surgeries on patients that are young, and we're talking 40s and 50s, because this isn't, these will be good for about 10 or 20 years most. So they usually reserve these to go for patients that are older, unless there has been some kind of trauma or injury to the joint. So one of the complications, well, let me talk to you a little bit about the surgery itself. And that is that the surgery on the hip can be from an anterior approach or a posterior approach. And it's strictly the preference of the physician. So either way, anteriorly or posteriorly, you are going through a lot of muscle, a lot of skin to get there. And so this is putting the incision to be very, very deep. Now, let's talk about surgery for just a minute. So when you have a cold, or you have a flu, or some kind of infection, some kind of virus prior to surgery, you've been on antibiotics and you get rid of the symptoms, do you still have some little particles of the virus or the bacteria floating through the blood? Yes, you do. So you are cutting through all this tissue, you are cutting through all the dermis here, and you are going into the bone. You're chiseling into the bone. So do you think that these people are at high risk for infection? Yes, they are. And plus, they are putting a foreign body, the hardware, into the bone. So, I mean, these people are super high risk for infection. And if they get it, oh my gosh, you're going to end up with osteomyelitis. And that is very, very difficult to cure. And not to cure, but to make it get well. It's not necessarily untreatable or uncurable, but it's very difficult to get that infection out of the bone and out of the tissues. And so it's really very important that when you in clinicals have a patient that has just had hip replacement, or that you have knee replacement, these patients are at high risk for infection. So you have to have infection precautions implemented when they come out of surgery, and you need to educate them about the signs and symptoms of infection, and what can potentially happen if they have. And I've known patients, it's not like I've known people, but I've known patients who are in the hospital for their 8th surgery after a hip replacement due to infection. So it's very hard on them. So it's a priority diagnosis for somebody that is having hip or knee replacement. Now, one thing that I didn't mention yesterday is that I told you that these are usually the weight-bearing joints, which they are. We do more hip and joint replacements than anything else. But literally any joint in the body can be replaced, even joints of the fingers. So I told you yesterday that ankle replacements are now becoming more and more common. So it's amazing that they can even do these things, because after the surgery, the patient should be free from pain. Now, we're talking about joint pain. They're going to be in pain because of the surgery, because of the incision and the trauma to the tissues. But the joint itself is not going to have that bone-on-bone pain because it's all metal. It's not belonging to the body. Okay, so one of the big complications of hip replacement surgery is dislocation. You have got, let's go back to that slide it was only one slide ago. Okay, so let's go back to this. Remember that after you have surgery and this new hardware, what is going on? There's somebody on the roof. Anyway, you have this new hardware in here. Now we have to develop scar tissue that will hold that ball in the socket. So until that happens, this is just metal, and it can easily slip out of the socket, and then you got a dislocated hip. So until scar tissue develops around this hardware, which will hold this ball in the socket, you are at high risk after hip replacement surgery for a hip dislocation. And so the thing about it is, if the patient experiences increased hip pain suddenly, and it's sudden, or there is a shortening of the affected leg, and you can see that this is the unaffected leg here. Can you guys see my cursor at home? I don't know. I'm pointing to my computer like that's going to help. So this is the unaffected leg here. This is the affected leg. Look at where the heel is here and the heel is on the dislocated hip. It's because this ball has jumped up. It's been dislocated, and now there's nothing holding it in place, so it usually moves upward to be dislocated. So the affected leg is going to be shorter than the unaffected leg. Also, there is going to be an internal leg rotation. Some of my students have seen this in the emergency room when they've been at clinicals, and it's been very interesting. And are these people in pain? That'd be a yes. So this is a huge risk post-surgery, and we need to contact a physician immediately afterwards. So the nurse, one of the interventions that she has to do post-surgically on the post-surgical unit is to elevate the head of the bed slightly, and then use an abduction pillow. Let me see if I got a picture of an abduction pillow. Anywhere? No, I don't have one. So an abduction pillow looks like a wedge, but we don't want the legs coming together because that ball will move to the outside of that socket. So we want to keep the abducted pillow in place, that wedge between the legs. Yes, ma'am? And 3 sides. Oh, thank you, dear. Thank you, dear. That was Megan that helped this. There we go. Yes, right here. So right here is the abduction pillow, and we want to keep them those hips abducted so that the socket isn't going to come out of place. So you want to keep the patient's heels off the bed because they're going to be in bed. Now, I say that for long periods of time, but I have to tell you, hip surgeries used to be 3-4 day stay in the hospital, and sometimes a little bit longer. They will go to rehab afterwards. Medicare, Medicaid services allows for 100 days of rehab, and then they literally kick you out of the facility. It's true. When insurance ain't paying, they're not keeping you there, whether you're ready to go home or not. So they will do rehab for 100 days and then go home. Hopefully they'll have some help at home. But so they get the person up and out of the hospital. It used to be a 2 or 3 day stay. Now it's down to 1 day. It's so sad. Insurance rules the world. But anyway, so what we want to do, though, is to be cognizant that their heels are on the bed. And so for periods of time, so they can't go from right to left immediately after surgery. So they are at risk for breakdown. So be cognizant of that. And then observe for a hip dislocation, hip pain, and we already just talked about that. So also, because this is an orthopedic surgery, we have to do our neurovascular checks and compromise. And some of the other interventions that we want to look at is the management of pain. We want to make sure that their activities of daily living, that we promote their independence in that as much as possible. We want to consciously require more of their activity daily. And it's going to be uncomfortable because they've had deep tissue. I don't know if any of you young people, which are all so much younger than me, have had a cesarean. Well, this would be just the girls, I guess. But the cesarean, you know, when you go through the abdominal muscle, it hurts. It is very tender. It's the same thing about the muscles around the hips. You make an incision through that, it's going to be very, very painful. And we want to monitor for hemorrhage and look for dependent drainage again. And then if they're losing a lot of blood, and this can be internally, they can have an internal loss of blood that is collecting within the thigh, then we want to monitor for hemorrhage. And so if you see an increase in pulse and then a decrease in blood pressure, you recognize that they're becoming hypovolemic. So again, as a nurse, you're going to observe the incision site for signs of infection. And look at this. I don't know if you can see this very well, but oh, does this look so tender? It is so red up here by the incision side, and you're going to see that it's a little tight because of the edema that is accumulating. And of course, there's going to be an increase in temperature and in pulse. Okay, so potential complications, of course, are going to be deep vein thrombosis because we are, again, doing surgery. So that is going to be problematic. Pulmonary embolism, this is also, they've been under general anesthesia. They're at high risk for that as well. So if they have a thrombus, they are at high risk for developing an embolus, and pulmonary embolism is going to cause them some trouble. You should know that. And now, drum roll, please. I am turning the time over to Madison. Are you there, Madison?
Yeah, can you hear me?
Yes, you're fabulous. Let me pull up your slide here. Oh, that's not it. Wrong one. Sorry. Sorry, Megan. Okay, here we go. Oh, I got to get this down. Hold on a minute. I got to get you pulled up here. Oh, there's people here. Okay, I was like, where's that talking coming from? Oh my gosh.
No. On the next tattoo. They don't be jealous. My whole life I wanted the next one. She was the next figure on profession.
Okay, hold on. I'm finding you. Trying to get your thing to come up.
You're good.
Is this showing on the computer?
You can see like the hip replacement surgery, like your PowerPoint.
This is a hip. It says discharge teaching after hip surgery. Is that it? No.
No.
Okay, that's okay. We will overcome. Yes, we will. All right, I'm going to try one more thing. Just a minute. So we're going to share the screen. We are going to do application window. We are going to go here. We are going to go, let's see, desktop. And this is going to be Madison.
Oh my gosh.
I went there before for our anniversary, but then my unreliable.
What happened?
They canceled my order because it was late.
Oh, well, let's take it.
Yeah.
Where are you buying this time?
I ordered them for my so my boyfriend said that so it's reliable and then so I just
Okay, I'm trying to get you to come here. Let's see.
Depends what they are. How recent.
They did sit in at 850 for a minute.
There's some that. There's some that.
Well, we got them on sneakers.
Oh, you got
When they were released. They were $100, right? And I was like, I don't care, they're $100. Hey, people are selling them for like $5,000. I'm like, sell your shoes.
Yeah.
He's like, we're not selling these. I'm like, sell the shoes, we're selling them.
Bro, you got the Travis, bro?
Yeah. We got them. We got them.
I'm jealous. I have to tell her the story.
I'm jealous, bro.
Problem.
I mean, what? I was on that sneaker that I was trying to get that.
Okay, are we there?
Yeah, we just couldn't see it on our part.
You can?
We can't.
You can't. All right, hold on.
These Jordans, those mocha Jordans.
Yeah.
That's $2,500. I'm like, sell them. I don't need these in our life. Shenanigans.
Here we go.
Got these for $15 at Nordstrom. So, we'll probably sell them later.
I don't need the resale value on it.
Okay, I'm almost there because I got to figure out now how to make this progress. Almost there.
Doing the Kareem
Yeah.
style.
It's the only move I have in Skype.
There we go. Okay, Madison, we're turning the time over to you.
Perfect. So I have discharge teaching for hip replacement surgeries. You can go to the next slide. All right, so just a couple of things before the patient is going home. So studies have shown that people who have joint replacement surgeries actually recover better when they go home, and they recover faster and have fewer complications. If they don't go home, they can go to rehab, like Vicki was saying. Something that they want you to have is, if you are going home, they want you to have someone there to help you after the surgery. And then the surgeon may recommend outpatient physical therapy. They are seen by like a physical therapist in the hospital, but they do like you to have outpatient therapy as well. So to be able to discharge from the hospital, it requires that the patient is medically healthy and to have achieved their personal goals for discharge. I kind of got a list from IHC about the goals that they need to complete before they discharge, but it's probably pretty similar for all hospitals around here. They have to be able to have their home health arrangements made if they need that. And they need to have a family member or partner take care of them at home. You can go to the next slide. So these are the goals that I found from IHC that the patient has to complete before going home. So they need to be able to get in and out of bed, up from a chair, into and out of the shower, and on and off the toilet without assistance. They need to be able to go up a flight of stairs safely, be able to put on some socks and shoes, and safely walk for at least 50 to 100 feet on their own, or with using crutches or a walker. They need to be able to perform their exercises on their own or have someone else help them. They need to be able to manage their pain so they can complete those exercises and their daily activities. They need to be able to eat and drink without difficulty and have necessary support and equipment at home. Next slide. Okay, so just a couple of things that we need to teach them before going home so they can be safe at home is to follow their therapy plan. So the PT will create a plan for that patient, and then the patient kind of determines how well that joint is going to work by following those plans. Like I said, they see a physical therapist in the hospital, and they're going to give them like a little sheet of a few exercises they can complete. But outpatient is usually recommended, and they'll get more exercises from the outpatient physical therapist. They need to watch for blood clots. So just kind of what we've learned, just watching for any swelling, any pain or tenderness in the leg, or any part of the leg that feels warmer than the rest of the leg. They need to be able to care for their wounds. So we just need to teach them to always wash their hands before changing a dressing, keeping the incision site dry and clean, and following the doctor's instructions on how to clean the area and how to do a dressing change. They need to follow the doctor's instructions on bathing and showering. And I thought this was kind of interesting, to not allow pets on or around the wound until it is completely healed. All right, next slide. So preventing falls is, of course, one of the most important things that they can do after the surgery and during their recovery. So it's important that they don't have others help them stand up or walk, because they risk injuring themselves and also that person that is helping them. So we need to teach them to keep their walkers, crutches, anything that they might need within their reach, and to teach them to take their time. So don't, hurry to go answer the door or the phone or whatever it may be, and to teach them not to wait too long before they go to the bathroom so they can take their time and get there safely. And then they'll have assisted devices like a walker, underarm crutch, forearm crutch. And the physical therapists in the hospital, they usually come in and teach them good technique on how to use this equipment. So as a nurse, we just need to make sure that they understand how to use it and answer any questions that they may have. I think the most important thing to make sure they know is if they're using like a walker, to make sure they don't put all of their weight on the walker when they're standing up, because that can slide from underneath them and they can get hurt that way. So next slide. The patient needs to be able to control their constipation. So we can just tell them to take stool softeners or laxatives if it's recommended by the doctor. They can add fiber into their diet or to fiber supplements. Walking and exercise. They can drink water, and of course to avoid foods that can cause constipation, like the dairy products, bananas, white bread or rice, and any processed foods. And then just to teach them how to their swimming. So just use the RICE acronym of the rest, ice, compress, either using stockings or ACE wrap. then to elevate. The next slide. All right. So then pain management with the hip replacement, they can either use medication or they can try to use or relieve their pain without medication. So if they're going to use medication, we just need to make sure that they understand to not take more than prescribed or more than the doctor told them to. Don't have someone wake them up to take the pain medication, or let you take more if you can't stay awake during meals or daily activity. Never use alcohol or street drugs when taking opioid pain medications. Keep the medication in the same bottle it came in and never share them, and then lock up the medications as well. If they want to go the route of kind of trying to relieve their pain without medication, they can use cold therapy, guided imagery or distraction, physical therapy or exercise, relaxation or meditation, or massage. Okay. And then just kind of teach them when they need to contact their primary care provider. So if the pain gets worse or they can't control it with their prescribed meds, if there's any problems with the incision site, so any bleeding or drainage, if the wound opens up, if blood or pus or a foul odor is coming from the incision, if they feel any numbness, tingling, or weakness in the arms or legs, any falls that they might have, a fever that doesn't get better after they take their medication, dizziness, lightheadedness, or fainting, blurred vision, persistent headache, if they haven't had a bowel movement within 7 days after surgery, nausea when eating or drinking, and then signs of deep vein thrombosis. Okay, so this is my learning activity. I hope it worked. There's just a little clip there. It's a 2-minute video. It's just kind of the do's and don'ts that you do after hip surgery. So I just want you guys, if you're online, just kind of write in the chat things that you either learned from this video or things that you already knew. And then if you're in class, just kind of the same thing, just turn to someone next to you or raise your hand and share with the class something that you learned or already knew about hip surgery.
Okay, thank you. I'm going to pull this up really fast. How long is this?
It's just 2 minutes, so it's pretty
Okay. We'll just look at that now. Can you see it or not?
quick.
I know.
No.
You can?
No.
Oh, okay. Because I don't pull it up.
I hope it works. It's a good
It was a
video.
thought. It was a thought. Okay. Great job. There's a couple of things that I do want to add to that about positioning the patient, because if you're going to be assisting them, then you need to know what they are allowed to do for hip surgery and stuff like that. And so, of course, we talked about the abduction pillow. We don't want them to cross their legs for several weeks. We don't want to have them cross their legs, you know, where a lot of times, like men sit with their upper leg that is in a square position. So we don't want them crossing their legs at the ankle, and we don't want them to cross their legs with one on top of the other raised high. I don't know if you know what I'm talking about or not. Anyway, we also don't want them to bend down and pick up objects off the ground, because again, that presses that ball to the outermost extreme of that socket, and we don't want to risk dislocating it. Also, we don't want them to, let's see, sit or extend the angle to 90 degrees. We always want it so that they do not go 90 degrees or less, because again, we risk dislocation. So what position do you get when you sit on the toilet? 90 degrees, don't you? Your hip goes at 90 degrees. So a lot of times they will have things called seat extenders or toilet extenders that will raise, you put it on the toilet seat, but it'll raise up that seat considerably so you don't sit at a 90-degree angle. There's little things like that that you need to know as the nurse so that when you're assisting your patient right afterwards, that you don't promote any kind of dislocation, but you have to have the knowledge level for that. There was one more thing. Let me just look at my notes here, because Madison covered it all really well. Just give me 2 minutes here. Okay, that's done. That's covered. That's covered. Okay, everything's covered. Great job. All right, we're moving on to the knee. So let me get out of this. See if I can even get back to my slides. And if I can't, it's okay. I'm not going to feel bad because we're almost towards the end here. Okay, so this is going to be, we're sharing. So we're going to share, but what are we going to share? Not this one. So let's bring that one down. And these ones up. And I'm going to go back to, I'm going to get rid of that because that's done. And wait a minute, share. Oh my gosh, do I have to go through this? Oh, here we go. So we're good here. Discharging from current slide. Ooh. You may applaud at any time because that went rather quickly, less than 15 minutes. Okay, so let's move on. Okay, so knee replacement surgery. All right, here's the same thing here. So the same concepts, basic concepts about doing knee surgery are the same as hip surgery. So let's say that you are having a knee replacement surgery that has been scheduled 2 weeks from now, and you have a cold today. And so you think, okay, I'll get over it, that type of thing. And you do have signs and symptoms, and you're going maybe a week before the surgery. Do you think you need to notify your physician at all? This we need to educate our patients about, because most of them don't put the two together. There's just not a lot of people that believe in the germ theory. So they don't understand that if they have cold or flu or any kind of sickness prior to going into surgery, especially a hip or knee surgery, then we need to notify the physician. They need to be educated to do that because it will be delayed. Physicians are all too aware of the risk for infection here. So we need to educate them about notifying the physician if they are sick at all prior to surgery. So with preoperative care, I say ambulate with assistance, turn, cough, and deep breathe. Why are we doing that pre-surgically? Why isn't that a post-surgical? Yes.
We can't see the presentation online.
Oh, I haven't pulled it up yet. Are you looking at my slide?
I'm just looking at the one that's shared online. It just says joint replacement surgery.
And does it say knee replacement surgery?
No, it's just the joint replacement. Yeah.
Yes, I was so happy. It was just such a brief moment in time.
I'm so sorry.
It's okay. No, I just feel so bad for you guys at home that are going, where is she? Where is she? Where is she? Oh, that's what you're seeing. I can understand why you're seeing that now. Okay, then let's, okay, so I want to bring up this. Let's see what's going to bring this up. Okay, so that's up. Shut up. There's complaints about me talking to myself. I don't understand. Okay, so Do you see discharge teaching with a total knee?
No,
Okay, fine.
I still see joint replacement surgery.
Cancel. So I'm going to get rid of this. So cancel. So I'm going to get rid of this. Oh, hi guys. All right. So let's try this. Oh, we're done with that. Give me a minute. Here we go. Okay, do you see that? Okay, that's okay. Okay, I'm excited. We're here. Let's see. I am going to let Megan go ahead and do this. Okay, Megan, I'm going to ask her right now. What does DKA stand for?
Oh, total knee arthroplasty.
Okay. Also for total knee amputation. I'm just saying, I know, yes, this is why you don't always use abbreviations in your documentation.
This is the official abbreviation.
Oh, I know, that's why I say this is why you don't use it in documentations, because people can think it's a total knee amputation.
I was like, no, this is it.
Okay, everybody can see it at home?
Yep.
Okay, perfect.
Arthroplasty is surgical repair of a joint.
You get control of the mouse.
Oh my gosh,
I
feel
know,
a lot of
it's
power.
a miracle.
Okay, background. I lucked out on this one because I used to work at Davis Hospital in their physical therapy department. So I did all discharge teaching for patients with total knee replacements going home.
Oh.
How do I go next? What do I do? Where?
Clicking, it's not,
No.
is it?
This is my only slide.
This is it. Okay, give me a minute. Am I going to be able to do this here? Oh, so let's go back down there. So let's share this, and let's. Give me a minute.
I have total faith in you.
I don't. Okay, so share screen. Well, let's see if we can do that with this. Share. Hide. Why does that have that? So you can't progress forward. That doesn't make sense to me. Okay, so let me just bring this up. I'm talking to myself again. All you people out there. On beginning.
Or what? Oh, is that this week? Yeah, this is a loss. What should I bring as my tree?
I don't know. That's what we were talking about now.
What do you guys want? I will just make like a whole thing on it. I don't like talkies.
Neither do I, but
Oh.
mostly that matters.
Oh, you did try that? With the cream cheese and the talkies? Was it really?
Yeah.
I follow on Instagram just the lady that does all my fitness talks, and some of them I'm like, there is no way that would be
She was a little spicy.
Dude, and when people put anything on a green bell pepper, I'm like, this is delicious. I'm like, no, a piece of pizza is delicious, not cheese and pepperoni. I probably like green pepper.
Yeah.
Yeah.
You're so good.
Yeah, I try to think cheese and everything.
Oh yeah. Yeah, people are like, I'm gonna live on this the rest of my life. I'm like, no, get on everything bagel and some cream cheese and you'll be set.
She's making one pizza.
Yeah. This one lady, I saw this one lady went to Wendy's. She's on keto diet. So you can eat anything that doesn't have carbs. So she gets a Baconator, takes the buns off, right? Because that's the only thing with like a high amount of carbs, and puts that in between 2 bell peppers. I was like, no, like you just want yourself to think that tastes good. Like that doesn't taste good.
Yeah, when people are like, you should try this keto pizza.
Yeah.
No, it doesn't taste good.
No, you're like,
Don't lie to
that's
yourself.
stupid. I don't want
You can say it
cauliflower.
tastes good, but it doesn't taste like pizza.
Cauliflower, and
Yeah.
the thing is it's not even rice. It's just like tiny pieces of cauliflower.
Yeah.
It's not like you made rice. out of
Okay, yay. Can we see this at home? Have we progressed?
No.
Oh my gosh.
it. Damn it, Daniel.
I know. Thank you. My words exactly. All right. I am so sorry, people. I'm trying to get this there. Trying to get it.
What? Oh, have you ever tried that?
They're really good.
Is it really?
They're really good. I mean, the only ones I have are like home video. My friend makes them.
My sister-in-law did like cauliflower buffaloes in her air fryer, and she said that was super good. But I've never tried it. I kind of was like, that seems crazy. Then I got one, made some wings. I was like,
Air fryers are the best.
and you put like some little dino nuts in there?
You think I haven't tried that? Come on.
Dude, I don't even have a kid. I got bags of dino nuggets in my freezer. In case the neighbors come over or something.
Oh my gosh. Tell me it works.
No. Still says joint replacement surgery.
All right. We're getting out of this. Hold on. This I'm saving because it works. So just a minute. And we're coming here. We're coming here. And
I have like an instant pot.
we're coming here. We're going to share.
It's amazing. What else is good? Oh, frozen French fries.
I'm like French fries and
Okay, we see it.
Well, I know, but now we got to make sure that it
What'd you make?
They're literally the best.
okay.
Are they like rolled tacos? or
Mark,
like-
do you see this advance?
No. Oh, yep.
Okay, we got it. Yay!
Takes a second.
Oh, yeah.
Okay, Megan, you're up.
Oh my
I think
gosh.
it's
That
actually going to
sounds
work.
so good. We're talking about air fryers and frozen tacos.
Goes well with knee replacement.
That is part of the discharge teaching is to eat tacos. This is a bad knee. That is a new knee. So total knee arthroplasty is the surgical replacement of the knee. It's pretty severe, and the healing after surgery, you're going to require physical therapy, rest, and recovery. Oh no. Oh, there it goes. So what do I need at home? These are things to do before you go home. And like Vicky said, to buy a toilet riser, people take home because you can't bend your knee very well after a knee replacement surgery. So to have to bend it to 90 degrees sometimes takes a couple weeks in physical therapy. So going home and doing it the first day won't be easy. And people do a shower chair because you can't stand in the shower for a very long time. So having a shower chair at home can help you to keep clean while you're at home. You also need a safe way to get into your home before you leave to go to your surgery. So before you go to the hospital, have a way that you're going to be able to get into your home on one leg. So whether that be putting a railing up next to your stairs, you can go upstairs with crutches or a walker, but making sure that there's a railing, or if there's not an option, finding a place to stay for a little while. One floor living is recommended, meaning that if you live in a 2-story home and maybe everything's on the main floor and your bedroom's upstairs, you just live on the first floor for a couple of weeks while you're healing. And then when stairs become easier, going back up and downstairs. And you also need help at home. You won't be able to take care of yourself at home alone. It will require someone, so whether that be like a spouse or a family member, or whether it be home health, coming into your house and taking care of you. And if those aren't options, you can go to a rehab or you can go to SNF. And in rehab and SNF, you would have 100 days to recover to go home. So safety once you get home, keeping the floor clean. We had a patient, I worked at Davis Hospital, and we had a patient who fell at home, their 3rd day home, and ripped their knee completely open. So the paramedics that brought him back into the hospital, he went right back into surgery. The paramedics said it looked like someone had died. There was so much blood loss because that incision just ripped completely open. So making sure your floor is clean so that you're not falling and taking time to get around. It's going to take a little while. Sometimes depending on the physician's preference, you might be like non-weight bearing for a couple days or like 50% weight bearing. So it takes time to walk around on one leg and one tiptoe. So don't be in a rush. Using the right equipment, depending on your capabilities. You might need a walker, a cane, or crutches. Usually anybody 50 to 55, we give crutches, and 55 and older gets a walker. And keep moving. That's part of being safe at home, is not sitting down for too long, making sure that you get up at least every other hour, walking around for a little bit, going to the bathroom, because it can make your pain worse because you'll just stiffen up and be stuck in that position, and you can also increase your risk for a blood clot. So medication and pain management at home, your surgeon will give you opioids. There is like no reason not to after a joint replacement surgery. It is very painful, and the weeks following are even more painful as you go through physical therapy. From a physical therapy standpoint, you want to make sure you're planning your medication around when you have physical therapy appointments. The worst thing you can do is come to physical therapy and not have taken pain medication for a couple hours because you're coming off of that last dose and waiting for your next dose, and then you're miserable because you hate your therapist and you're in a lot of pain. So planning your therapy and medication times together. You'll use NSAIDs, Tylenol. Always take it as prescribed. Waste your unused ones. Be smart. And then ice and heat. You want to be careful with heat because it can increase inflammation. So usually heat is just used before therapy, or if you're really stiff in the morning, you can use heat for like 15 minutes, loosen the joint up, and then you want to make sure that you keep moving though so that inflammation doesn't keep getting worse. Rest, obviously, relaxation and meditation. Ice massage is really good. So you'll get a styrofoam cup. You'll fill it about half full with water, and you'll tear off the rest of the styrofoam. So you just have a little tip of the ice on top, and you just rub that straight onto your knee for about 5 minutes only. It's real quick, and it freezes you up really nice, and you feel really good. And then if you believe in this stuff, if you're from Utah County or Kaysville, lavender oil and yarrow oil are good, have been found to help. So find your local essential oil lady on Instagram. So things to watch for at home. Signs and symptoms of a blood clot, redness, pain, heat, and swelling. Most of the times, though, that's going to be in your calf. It won't be right on top of the joint that's been replaced. It'll be in your calf muscle. So you want to just, if you feel like it's getting tighter, some of that can be from therapy, but you would want your therapist to check or yourself to check. And if you have any concerns at all, call the surgeon and they'll get you in for an ultrasound just to make sure that it's not a blood clot. Infection in the incision, you want to watch for drainage, redness, swelling, increased pain, numbness or pins and needles in the extremity. So doing your CMS checks or a new fever can be a sign, as you smart people know, of an infection. So physical therapy is a huge part of teaching your patient on their way out to make sure that they see their therapist within 2 to 4 days. They're going to leave the hospital with an order for physical therapy. And most times a surgeon will have like a preference of who they work with. So I worked at Davis Hospital and they contracted with Wasatch Peak Physical Therapy, and that's who I actually was employed by. And it's Utah Orthopedics over there. They have a contract with Wasatch Peak. So every time all those patients were coming to us. So that's why we did all of our discharge training, and we scheduled them in the hospital for their first outpatient appointment. And that's going to be 2 to 4 days after. And then unless you're going home with home health, we have home health physical therapists that'll go home to you. And it might be 2 to 4 weeks you're seeing them at home, and then you'll come to an outpatient clinic. Listen to your therapist, follow your home exercise program, and don't do too much too soon. Your home exercise program we're going to do for my learning activity, but just making sure you do it every day, because then when you go to your physical therapy appointments, you've actually improved and you've been working. So it's not like you're just doing a killer workout 2 times a week and resting the rest of the days. And you'll see your therapist for 6 to 8 weeks, usually 2 times a week, just depending on your improvement. Some people are less. We had one guy come for like 14 weeks, 3 times a week. Then he got a new one because that one failed. So this is my learning activity. These are home exercises you want to do once an hour. So we're going to do them all together. People at home, you're going to do it all together. So the first one, this is called a quad set. So you're just tightening your quad and relaxing. It's kind of hard in the chair. Your butt might squeeze more than your quad does, but just tighten your quad and relax. Butt squeezes, though, are good for hip replacement surgeries. So you'll hold it for 3 seconds, and we'll just do 5 of them. We don't have to do 30. I'm just squeezing my butt because I can't really squeeze it when I'm
kind
standing.
of like a Kegel, isn't it?
Yes. Yeah. Then you can see your women's health therapist right after. So that's a quad set. Then your heel slides are ones that you're going to do. You can sit in your chair, so just slide back a little from the desk. And then with starting, you'll extend your knee out and slowly pull it back. So keeping your foot on the ground, though. And you'll pull it back. That's your heel slide. So you should normally do this sitting, and you want a patient to gently pull towards them. While they're in the hospital, they'll be on a CPM machine, which will do this for them. Back and forth for like 8 hours a day. And then last one you want to do at home is just a long arc quad or just to kick out. And those ones just kick straight out. And right after a knee replacement, if you can get 2 inches off the ground, that's what we like to see. So you all are fabulous in it. So that's my presentation. There's my references. There's my friends at Wasatch Peak Physical Therapy.
There you
I
go.
stole their discharge teaching.
There you go. Thank you so much. There's a couple of things that I wanted to add. Of course, I always get the last two cents, don't I? Megan talked about being on opioids afterwards. And we talked about that they were probably on opioids a month, 2 months, maybe even 3 or 4 months prior to surgery. And so now we've got to start the withdrawal process. Now we've got to talk to them too about how to do that and what some of the signs and symptoms are going to be. So what do you think some of the signs and symptoms are going to be for any withdrawal of opioids? That's when you're going cold turkey. But when you're trying to wean yourself off of them, as we are instructing them to do, the signs and symptoms are going to be the opposite of whatever the opioid does for you. So if the opioid relieves your pain, are you going to have pain? Yes, you probably will. If the opioids make you drowsy, what are you going to have? Insomnia, you're going to be agitated, you just can't sleep, you can't rest appropriately. If you have constipation with opioids, what are you going to have when you're starting to go off of them? Diarrhea. So just be aware of that and some of the warnings, or we prefer education, about what some of the signs and symptoms are going to be, and that's normal when they are withdrawing. And there was one other point that I was going to make. Oh, the CPM machine. So Megan mentioned the continuous passive movement machine that happens right when you come out of surgery. So do you think when you've gone in and had this fabulous $50,000 new knee put in that you can get up and walk out? No, you can't. So what happens is you lose your range of motion in that joint till the inflammation goes down. This is why you have so much ice therapy, and you're putting ice on the knee all the time to try and minimize some of that swelling, because swelling is going to decrease your range of motion. But with the continuous passive movement machine, what they're trying to do is have that machine assist in you maintaining the angle of range of motion that you have, and increase it slightly, progressively day by day, so that you don't end up with a stiff knee. Now, there again, like with the hip replacement surgery, the joint itself will no longer be of discomfort or pain to the patient. However, they have gone through major surgery. And so the disruption to the tissue, the inflammation, is going to be extremely painful to them as they recover. So they're not going to voluntarily, increase their range of motion. So these machines are wonderful. However, they're not as used as often as they used to be. It used to be they'd come out of surgery and they'd come up with the CPM machine, and the nurse would hook them up to it, slap some ice on top of the knee, and turn the machine on, and it would already start moving. Now the angle would only be maybe 5 degrees or so, not a lot of movement, but we're wanting to get it movement so that edema, the ice will help minimize the edema, but the movement will help that edema to get reabsorbed, and so that you're not going to lose any range of motion to that joint. So like I said, you may see it, you may not see it. It may be wait until they go into rehab for the knee. I got to tell you that I mentioned that I've had 2 knee surgeries, and rehab is the most fabulous thing in the world. It's not like going to the gym where you sit there and you push to the outer limit. It is just constant progressive movement of the joint, and it never went home with any pain after the therapy. Okay, there's one last slide that I want to talk about before we make a break, and then Chantel will come in at 9:30. I will tell you that, again, you have a learning assignment due, not an assignment, an activity tonight at 11:59. And notice that these assignments are more participation points rather than grading them for their content. And then tomorrow I will publish the answers to the learning activity. But these are used, or these are here to help you, number one, learn, but also to provide a resource for you for a study guide, as a study guide for the upcoming test. So, don't totally negate these as not being worth the time. And then one other slide that I wanted to, and also the review for exam number 9. How many exams do we have? 11. So we're getting down, people. So for next Monday, exam number 9. So the review for that, I will record tomorrow morning. And I don't have the workload this week that I had last week. So hopefully I'll get it published by tomorrow afternoon. Okay. one last slide that I want to talk about, and there is no objective for this slide, but I fear at night I stay awake worrying that you're going to have a question about gout on the NCLEX. So let me just throw this out there as part of the musculoskeletal lecture. But you don't have to memorize this. You don't have to, but you need to know about it in case you see a sign or see a question about that on NCLEX. So a gout is basically a buildup of uric acid in the peripheral joints. It's often found in the big toe. Has anybody ever seen somebody with gout? Oh my gosh, you don't even want to touch it for them because it's in the distal extremities. You're looking around the toes, the big toe. It's so swollen and red and tender. It's shiny. It's just so tight. So and it's in the big toe. Anybody ever stub their toe? Yeah, well, it hurts. So when you have this big toe that is now just swollen and full of these crystals, they're little, the uric acid is in the form of crystals that it's so painful to them. And of course, we're wearing shoes. So anytime you knock your foot or even the shoe rubbing up against the toe is extremely, extremely painful. It's usually, interestingly enough, comes up with men. Men, I have a greater majority of experiencing it than women. People are seldom hospitalized for this. It can be treated at home, but they will get some medication for it, which is going to help the uric acid get excreted from the body. So they can appear in the kidneys, causing a kidney stone. So it's all I can say to you. It's very, very painful, and the treatment for it is that you will get medication for that. It may be reoccurring. So I'm just telling you that just so you know it. Because why? Because Davis Tech students going into the NCLEX, they rock it because they know a little bit of something about everything. All right, people, any questions before I sign out of this fabulous software that I have come to know and love? Anything coming up, people, since I can't see it? Nope. Let me roll down. Yay! All right, people, we are here for you. I know you think that sounds like we're saying that in vain, but we are. If you need anything, any questions answered, any help, any strategies that you want to talk about, schedule a time and we'll get you on conference and we'll make it happen. And with that, I say, peace out.